Welcome to this video presentation on harm reduction theory and practice. CLPNA is pleased to welcome guest presenters Sarah Gill and Tahira Morali from Alberta Health Services. Sarah is a registered nurse and educator from the Provincial Harm Reduction Services team at Alberta Health Services. She has extensive experience in outreach and supervised consumption services in Calgary and public and community health in Vancouver's downtown east side. She is passionate about supporting the inclusion of harm reduction practices in all areas of healthcare delivery and is a strong advocate for people impacted by substance use. Tahira is the Calgary Zone Lead on the Provincial Harm Reduction Services team at Alberta Health Services. She is a registered nurse and has worked in inpatient psychiatry and forensic psychiatry. Prior to her current role at AHS, Tahira worked on the Assertive Community Treatment team at the Supervised consumption site and has extensive case management experience. Tahira is passionate about promoting harm reduction and making it accessible to everyone. She is a strong proponent of trauma-informed and person-centered care and the essential value of those with lived and living experience. Please join me in welcoming Sarah and Tahira.
We would like to begin by acknowledging that we are on traditional and unceded lands, referred to as Treaty 6, Treaty 7, and Treaty 8 territory, and we are all beneficiaries of these peace and friendship treaties. This land is home for many Indigenous peoples, including the Blackfoot, Cree, Dene, Saulteaux, Ojibwe, Stoney Nakoda Sioux, and Tsuut'ina people. It is also home to the Métis Nation of Alberta and the Métis settlements. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with Indigenous communities in the spirit of reconciliation and collaboration.
I'd like to start by talking a little bit about my team. The Harm Reduction Services team formed in 2018, and we are a provincial team responsible for the community-based Naloxone program and enhancing Naloxone distribution and education practices across Alberta. Our team supports harm reduction learning and practice within Alberta Health Services and serves as a resource for policies that pertain to working with people who use substances. We partner with community organizations and programs to strengthen the recovery-oriented continuum of care for people who use substances through awareness, improving access to harm reduction services, and reducing stigma and discrimination. On screen, you'll see the Alberta Health Services zone map. Our team is comprised of zone leads who can connect with and support our partners in their respective zones. We can be reached by email, or you can visit our website for some of our resources on harm reduction and the community-based Naloxone program. My goal is to provide you with an understanding of how harm reduction fits into the continuum of care. This presentation will cover the definition and principles of harm reduction and how you may already be familiar with the concept, what harm reduction services are like, and what harm reduction looks like in practice, with a focus on stigma, trauma, and acknowledging people's lived experience. So what is harm reduction? This is our definition of harm reduction at Alberta Health Services. Harm reduction is policies, programs, and practices that reduce adverse events or harm related to the use of psychoactive substances without requiring a reduction in use or abstinence. Psychoactive substances are any substances that alter mental processes, that is, behaviors, feelings, or thoughts. It includes legal and illegal substances and does not imply abuse or dependence. When we look at harm reduction outside of the realm of substance use, it might be referred to as risk mitigation, risk management, or safety planning, something we do instinctively every day. It's promoting public health through health promotion and prevention, focusing on wellness for the individual wherever they are in the spectrum of substance use. Harm reduction can look like education, skills and capacity building, providing support or resources, referrals and relationship building, and as we'll discuss later, is provided by a variety of programs in the continuum of care. Some examples of harm reduction you may already be familiar with include personal protective equipment, first aid kits, vaccines, public sharps disposal bins, Naloxone kits, condoms, speed limits, and of course seatbelts. These are some guiding principles of harm reduction collected from various harm reduction organizations, training manuals, and research literature. Pragmatism is recognizing substance use as a universal phenomenon. People have been taking substances since the beginning of time, and that use can be viewed on a spectrum.
Despite risks, substance use also provides people and society with some form of benefit, and this must be taken into consideration. It's important to ask what benefit people are obtaining from substance use to better understand the situation from their perspective. Human rights. Respecting the basic human dignity and rights of all individuals who use substances. The non-judgmental acceptance of a person's choice to use substances is at the forefront of harm reduction, while encouraging informed decision-making. Sometimes it isn't realistic or desirable for a person to stop using substances. Sometimes it can actually cause more harm, and reintegration into society is emphasized over social exclusion. Focus on risks and harms. A person's substance use is secondary to the harms that can occur from the substance use itself. Priority is placed on the negative consequences to both the individual and the community. In some cases, rather than abstinence, reduction in the amount or frequency of use may be one of the most effective forms of harm reduction. In others, a change to a safer method or mode of use may be a more practical and effective approach. The best option will differ from person to person based on their unique circumstances. Maximize intervention options. Recognizing that people have unique needs and that the most beneficial approach is to use a variety of different interventions. Interventions should be flexible, creative, low barrier, and involve a holistic approach with a wide variety of options for both the individual using substances and the health or service provider. Priority of immediate goals. Envisioning a hierarchy of achievable steps that can be taken one at a time, prioritizing needs as determined by the person using substances. Incrementalism. Recognizing that the small steps toward a goal are more important to focus on than the end goal itself. For example, making it to 2 appointments in a row or cutting back on use. Goal planning for recovery are all wins to celebrate. Whatever it is the individual is succeeding in, build on these successes to foster strength and empower them to get to where they want to go incrementally. Involvement of people with lived experience. From policy and program planning to service delivery, involving people with lived experience in substance use or loved ones impacted by substance use is important in ensuring that services are informed by their experiences and will actually meet people's needs. This representation matters and is echoed by the often heard call to action of nothing about us without us. Evidence-based. Harm reduction is a public health approach based on scientific research and years of evidence that it is effective at reducing harms and death not only to the person using substances, but to the community at large. Social justice and accessibility. Beyond the clinical focus, harm reduction can also be seen as a movement towards social justice, calling out and addressing systemic barriers that prevent people from accessing necessary social and health services and more. Low barrier access is a norm of harm reduction that we will go over later. A continuum of care is the delivery of services across sectors by different healthcare providers in a coherent, logical, and timely fashion. This can be viewed through a lens of recovery from addiction, or more broadly, the provincial healthcare system. When it comes to the recovery-oriented continuum of care, harm reduction is a vital component at every step. It can be a life-saving measure that should be available to people at risk of harm from substance use and can be applied anywhere in the continuum, from screening and assessment to sustained recovery and in all healthcare settings. The path of the patient through the continuum is not always linear. We all work within this continuum and are caring for patients who use substances or are impacted by substance use. Adopting a consistent approach to substance use that is compassionate, non-judgmental, and person-centered can improve patient or client experiences and success in meeting their wellness goals. Recovery is self-defined and looks different for every person. It's meeting a self-determined goal. Recovery may not always mean abstaining from substance use. The recovery-oriented approach is an approach to empower people experiencing substance use and mental health issues to use their strengths and their skills to live the life they choose. The recovery-oriented approach and harm reduction approaches to care are similar and compatible. They recognize the inherent value of the individual, consider how relationships with loved ones, the community, and healthcare providers impact and play a role in recovery. Both accept that abstinence may not always be realistic or desirable goals for the individual, and that substance use shouldn't be a barrier to accessing services. Both honor values, preferences, and cultural practices of the individual and their family. These unique individual needs and life experiences inform care planning and delivery.
Both focus on the strengths of the individual to build them up and empower them to gain control over their life and health. Both are non-judgmental, non-stigmatizing, and address systemic barriers to recovery. The benefits of harm reduction can be viewed at the individual, community, or societal level, and different types of benefits have been identified. Health benefits include improved physical and mental functioning. Social benefits are improved order and inclusion in society. And economic benefits are seen in financial costs and gains. Benefits for the individual look like HIV and hepatitis C prevention through decreased sharing of substance use equipment, decreased emergency department visits and deaths, connection and referrals to health and social services and treatment programs, empowerment and capacity building, and restored dignity and self-esteem. For the larger community, this looks like increased safety, restored connections, more inclusive communities for people impacted by substance use, decreased costs to the healthcare and justice system, and improved population health outcomes. The Alberta government has a substance use surveillance system that allows the public to view current data related to substance use, including access to healthcare services, prescription treatment, naloxone, drug poisonings, emergency responses, and deaths. Why do people take psychoactive substances? The simple answer is that people take them to feel better, for a variety of unique reasons. You can see some examples on this slide. Recognizing that people do things for a reason, a benefit, is an important first step to providing good recovery-oriented care. Seemingly harmful health behaviors may be providing some benefit to the individual, and these benefits must be acknowledged and assessed to be able to provide safer alternatives or support. Weighing the risks and benefits and understanding how we can mitigate risks around harmful behaviors is harm reduction. Looking at the reasons on the previous slide, it's likely that we will all take psychoactive substances at some point in our life. This might be an over-the-counter medication for allergies or prescription medications for anxiety or pain. It might be alcohol, nicotine, caffeine, or cannabis, and for some, it might be an illegal substance. We choose to take these substances because they serve a purpose. It's so important to emphasize that psychoactive substance use is common and normal. This spectrum is a communication tool that we developed to support conversations about substance use patterns and risks. It is not meant to be a diagnostic tool, but a conversation aid. It depicts use patterns that might be perceived as beneficial with little harm, casual or low risk with negligible adverse effects, for example, social smoking or drinking, high risk or harmful use with apparent negative effects for the person and those around them, and chronic dependence, which is compulsive chronic use despite negative consequences, or a diagnosed substance use disorder. So, for example, using despite loss of home, job, or family. Not everyone who starts using substances will progress to chronic dependence. A person can move back and forth along the spectrum. Where they are will vary based on substances they are taking, circumstances in their life, and wherever a person may be in their use, there is accompanying risk of harm, and harm reduction is something used to address those risks to prevent harm. Harm reduction services meet people where they are in their substance use and needs. They accept that abstinence may not always be realistic or desirable goals for an individual. They can be provided to the individual, the family unit, community, and to society. They are low barrier, which means they're mobile or available on outreach with flexible hours and inclusion criteria. They can be viewed as a spectrum of interventions that vary depending on individual needs. In the following slides, we're going to look at different harm reduction services that you might refer individuals to or encounter in your community. Supply distribution and recovery programs are programs that provide naloxone kits and injection, snorting, inhalation, and safer sex supplies to the public at no cost. These programs may be at fixed sites or available on an outreach basis, either through mobile van or on foot. You can see a picture of the SafeWorks outreach van here in Calgary. They may also collect used sharps for safe disposal and do walks on outreach to pick up any substance use debris for safer disposal. These programs used to be called needle exchange programs because they operated on a one-in, one-out basis. That is an exchange of supplies for used items. But best practice is to provide people what they need and not create barriers to accessing services. Engagement and relationship building are at the center of the work of these programs, as stigma and lack of trust can prevent people from accessing services. Education and referrals to other programs are often provided during these brief interactions. Supervised consumption services and overdose prevention sites are government-approved spaces where people can bring their pre-obtained substances for consumption under supervision of staff who are trained to respond to adverse events like poisoning or seizure. These sites are often staffed by multidisciplinary teams that can provide wraparound care. In Alberta, accepted routes of consumption at supervised consumption sites are typically injection, ingestion, or snorting, depending on the site. Often these sites facilitate access to other services in the continuum of care, for example, medical care, social work, housing, and financial supports, withdrawal management, treatment, support groups, and more. There are now also virtual supervised consumption services by app or telephone available for those who would prefer to use alone or do not have a choice otherwise. Trained phone operators take calls and check in with callers regularly post-use to engage emergency services as needed or to provide psychosocial support or referrals to other services. Engagement and relationship building are also of utmost importance at these sites to create a welcoming environment that clients are able to return to for support. Brief interactions in these programs present opportunities for them to move toward their goals, whether that goal is treatment, abstinence, or even just using more safely or taking a break from use. These are pictures of the SafeWorks supervised consumption site in Calgary. These are the supervised consumption sites available in Alberta today. You can see pictures of the Royal Alexandra Hospital inpatient site here. Virtual service availability may vary depending on location. For help on where to find harm reduction supplies or supervised consumption services, our team can be reached by email for support. Community-based naloxone programs allow for a variety of programs within the continuum of care to distribute naloxone kits for free to the public to address and reduce accidental opioid poisoning deaths in the community. Kits should be available to anybody at risk or likely to witness opioid poisoning at no cost and in a low barrier fashion that does not require identifiers or need to disclose or prove risk. In hospital or when providing care, kits should be available at any point a patient requests or demonstrates risk for poisoning. For example, on admission, on discharge, if leaving the unit on pass, leaving against medical advice, disclosing use, or requesting harm reduction supplies. Ideally, anybody with a prescription for opioids should be offered a kit when picking up their medications. Training on use of the kit should be offered. There are many training tools on our community-based Naloxone website, but a kit can still be provided if a person declines training. Harm reduction can be found across the spectrum of care, and here are many examples of programs that serve people who use substances with a harm reduction approach. Opioid dependence treatment or opioid agonist therapy, often referred to as OAT or OAT, is an evidence-based medication-assisted treatment for people diagnosed with opioid use disorder. Typically, it involves buprenorphine or methadone, and sometimes hydromorphone and long-acting morphine. Some patients may be prescribed other medications to support this treatment. These medications help reduce cravings and withdrawal symptoms to allow for stability and improved quality of life. When a harm reduction lens is applied to opioid dependence treatment, it can reduce the risk of poisoning and provide ongoing opportunities for engagement in change. Managed alcohol programs are harm reduction approach to alcohol use disorder. Patients on managed alcohol are usually experiencing serious health complications related to alcohol and may be unable to engage in abstinence-based approaches. Ongoing research is happening through the Canadian Managed Alcohol Program study. Managed alcohol is available at the Royal Alexandra Hospital, the Peter Lougheed Centre, and several long-term and supportive and harm reduction housing facilities in Alberta. Specialized addiction consult teams like the ARCH teams in Calgary and Edmonton are also available to provide recovery-oriented and harm reduction services in the hospital with the goal of having a successful admission and reducing repeat admissions for the same or worsening health problems. Many addiction and mental health and public health programs integrate their work with harm reduction when it comes to assessment and treatment planning, outreach, case management, counseling, and crisis support, and even residential services. Sexual health and communicable disease control services often test and treat bloodborne infections and distribute naloxone kits.
Health promotion programs provide education on safer substance use and awareness campaigns. In the community, peer advocacy groups such as AWARE and Moms Stop the Harm are important voices who provide services like education, supply and naloxone kit distribution, community events, and psychosocial support. They advocate for change in harmful drug policies and promote compassion for people impacted by substance use through sharing their stories and experiences with substance use. Awareness campaigns such as those about fentanyl, cannabis, and alcohol and impaired driving are also forms of harm reduction. Street drug testing services allow a person to test their drugs for potential contaminants prior to taking them. You might find these at dance festivals or through mail-in services outside of Alberta. Drug alert systems allow for sharing of information on new and dangerous substances or identified toxic batches of drugs. In practice, the harm reduction approach is non-stigmatizing and welcoming, low barrier, flexible and accessible, person-centered, focused on relationship and trust building, trauma-informed, and strives for cultural safety. Stigma contributes to a host of adverse outcomes for people who use substances. Stigma can be categorized into different types. Social, structural, and self-stigma are some examples. Social stigma consists of negative attitudes, labels, and images in everyday conversation and in the media. Structural stigma comes from people who offer services to the public. It is ignoring people affected by substance use or not taking their requests seriously, not connecting people with health or social services because of their substance use, and designing health and social services in a way that enhance stigma, such as withholding health or other services until substance use is better managed. And self-stigma occurs when a person internalizes social and structural stigma by taking those negative messages about people who use substances and applying it to themselves. Self-stigma can look like anger, difficulty engaging, shame, and self-destructive behaviors. It's easy to see how different types of stigma interact with and perpetuate each other, and imagine how eliminating stigma could have significant health and social benefits for people who use substances. We as healthcare providers are challenged to acknowledge and address our own internalized stigma. Health Canada recognizes stigma as having a role in preventing quality care and a barrier to accepting harm reduction into practice. It is so important for us to understand this. For people who use substances, stigma has the power to perpetuate hopelessness, negative self-concept, social isolation, and fuel a reluctance to access health services, which can worsen health problems. When care is accessed, people receive decreased quality of care, which makes them less willing to come back for future or ongoing treatment of their health condition. In the end, people end up presenting to healthcare facilities with more advanced illness. The language and words we use matter and have great impact on how our patients perceive themselves, their care providers, and their care. Words like addict, junkie, and user dehumanize and convey judgment. It's best to use neutral and medically accurate terms to describe substance use. Note that a person with lived experience may use these terms to describe themselves and may prefer them, and that's their right. We as care providers should strive to use compassionate, respectful language. When you don't know what language to use around substance use, it's okay to ask your patient or client. It's okay to be uncomfortable and to share your discomfort. Sharing your vulnerability can help build trust and rapport. We want to use person-first language that focuses on the person and not their actions or condition. Instead of drug user, say person who uses substances, person with substance use disorder, person with lived experience. Note that it is always better to refer to people by their name first than by their diagnosis, procedure, or room number. Use respectful and positive language and avoid slang. Instead of clean, try person in recovery. The same applies for language around urine drug tests. Results are either positive or negative rather than dirty or clean, which implies that people who are using are dirty. Keep in mind that respectful language is evolving as we become more aware of how our words and actions impact others. What was seemingly okay to say last year may now be considered inappropriate or dated. Just do your best. Some other suggestions for reducing stigma when caring for people impacted by substance use include being aware of your own values and ensuring your practice is neutral, non-judgmental, and ethical, being aware of your body language. People can be sensitive and interpret nonverbal cues differently based on their past experiences, protecting people's privacy and confidentiality, asking only the questions relevant to their care, using open-ended questions, advocating for others, not taking anger or frustration personally, giving options and choices and involving the client in their care plan, and encouraging coworkers to see behaviors based on the context of people's lives and past experiences. Briefly touching on the social determinants of health, these are the conditions in which we live, work, and play. Health and social inequities put people at risk from many health conditions. Substance use is complex and is influenced by a combination of biological, psychological, and social factors. Social determinants of health have a profound impact on risks for developing a substance use disorder, as well as access to treatment and sustaining recovery. Social isolation, poverty, and discrimination have been identified as particularly significant. When working with people experiencing health and social inequities, it's important to ask questions to get an accurate picture of their needs. A person who is living in survival mode may not be able to engage in their healthcare. Ask about housing, income, food security. Ask about social supports and safety. Ask about early life experiences in a trauma-informed way. Explore structural and social factors that may influence health and substance use. For example, safety, unemployment, pain, stress, barriers to accessing equipment, and help them identify resources that may address these factors if you yourself are unable to. We've used this term several times now. Low barrier or low threshold services remove real or perceived barriers so that people are better able to access services they need. This means low or no cost services, flexible hours and locations, minimal inclusion and exclusion criteria, and anonymous services. Really, whatever you can do to help a person get connected to a service they need. Trauma overwhelms a person's capacity to cope and interferes with sense of safety, self-efficacy, and ability to regulate emotions and navigate relationships. Trauma may be specific events that should have never happened in a person's life, like abuse, war, loss, accidents, or it may be specific needs not being met that have a profound impact. Trauma can be a single incident, complex or repetitive, developmental, intergenerational, or historical. Substance use is one way people may cope with the pain of trauma. People respond to trauma differently, and that's human. Trauma-informed care is based on the premise that trauma is very common and the assumption that every person has experienced trauma. Trauma and violence-informed care is about creating an environment of safety, acceptance, and non-judgment, as well as a purposeful effort to avoid re-traumatization and perpetuating feelings of loss of control or powerlessness. Trauma and violence-informed care expands on trauma-informed care by including the impact of structural violence, so inequities related to social determinants of health that are embedded in social structures such as poverty, homelessness, lack of affordable and safe housing, and gender-specific services. Trauma and violence-informed care ties together social determinants of health, experiences of trauma related to social determinants of health, and looks to promote health equity, improving their psychological state and social circumstances. We can lessen the effects of structural violence by recognizing, acknowledging, and challenging barriers to health equity and policies that cause harm. This can be in small ways like advocating for more accessible and improved quality of care or supporting health policy changes. Alberta Health Services has a series of trauma-informed care modules linked at the end of this presentation. Putting trauma and violence-informed care into practice means ensuring that staff receive training on trauma and violence-informed care and are supported to remain safe while working with clients experiencing trauma and violence, creating safe spaces for both clients and staff, privacy when having vulnerable conversations, screening for history of trauma and being mindful of and addressing risk of vicarious trauma. Being flexible may mean adjusting the place of care to one that feels comfortable and safe, moving to a non-co-ed room or a light on at night, informed consent before tasks and procedures, transparency about information sharing, respectful inclusive language, and advocacy for structural and policy changes. Cultural safety is based on the principle that patients decide what is safe or unsafe for them. They are the experts of their lives, and we as care providers should yield control to them anywhere possible when participating in a therapeutic relationship. Culturally safe care is complementary to harm reduction in that it fosters engagement and participation of people in shaping their care. This is done through active listening, an acknowledgement of concerns and needs, transparency and openness about patient rights and what to expect in care, seeking opportunities to learn from our patients about their lives, their needs, preferences, and perspectives. Culturally safe care recognizes that lived experiences and the history and politics contribute to how people might view the world, and specifically substance use. It requires care providers to reflect on their own attitudes and beliefs about substance use and how drug policies may have shaped them. It builds on this awareness by promoting awareness about the environment in which we provide care. Education on trauma and violence-informed care aligns with the practice of culturally safe care. Culturally safe care recognizes that trauma, violence, layers of disadvantage, and stigma affect people's ability to engage with care providers. Some things we can do to practice cultural safety include rapport building before clinical conversations or assessments, asking the individual what you can do to make them feel safer. This can provide insight on their perspectives or experiences, asking open-ended questions and explaining the rationale for them, as well as actions and decisions that might follow, informing patients and clients about their right to decline to answer questions and request clarification, avoiding assumptions about behaviors, for example, sexual practices or substance use, based on age, sex, race, relationship status, education, socioeconomic status, appearance, etc. Using clear, neutral, inclusive language, being flexible, adaptable, and extra supportive with options and decision-making, diverse staff that reflect the community demographic, accommodating people of different literacy levels and cultural backgrounds. It's important to look for opportunities to learn from our patients about their lives, their needs, their preferences, cultural norms, and their perspectives on care. So often we speak of meeting people where they're at. This can be viewed not just through understanding where the person is with respect to stages of change, but levels of privilege, barriers they face in society, social determinants of health, abilities, trauma, among many other factors that make them unique. Understanding this will help us better support clients with low barrier options appropriate to their needs and circumstances, and contribute to a systemic change that will hopefully ensure that people are able to access services they need without fear or judgment. When we work with people who use substances from a harm reduction lens, we are not necessarily aiming to reduce substance use, but we're always assessing for risks or potential harms and thinking of safety. Here are some points to remember when conversing with people who use substances. Safety plan. Do they have a safe place to go? Do they have a plan for preventing or responding to poisoning? Do they have naloxone or know where to get it? Are they using substances alone? Safer use. Review safer substance use education with them. Discuss safer use methods or practices around prevention of bloodborne or injection-related infection or injury if able. Discuss potential safety plans. Supplies. Do they use sterile consumption or safe for sex supplies? Do they know where to get new sterile supplies and how to dispose of their supplies safely? Support. Do they have a support system? Do they know how to access resources? Can you share numbers for distress lines, shelters, meal programs, drop-ins, or outreach programs? Ensure that they know how to access supports outside of your clinic hours, for example, 24/7 supports, flexible options, outreach teams. If possible, make referrals for patients while they are in clinic with you and introduce them to the referral or the practitioner. Follow up with patients after referral visits to ensure that the plan of care is clear and updated as needed. When working with people who use substances, it is really valuable to feel comfortable discussing safer substance use practices. Some examples of safer substance use messaging that you can share with patients or clients or people you care about who use substances can be found here. Avoiding using alone is always best. Use at supervised consumption services or use with others in a staggered fashion so that someone is always available to call for help in an emergency. Always doing a test dose. Starting low and going slow to check for tolerance and any unexpected effects of the substance. Knowing your tolerance. It doesn't take much to decrease tolerance. Some reasons for reduced tolerance include the short periods of abstinence one might have if they were hospitalized, just out of detox or treatment, or correctional services. As well, being ill can reduce a person's tolerance. Reduced tolerance increases a person's sensitivity to drugs and their risk of poisoning. Avoid mixing substances. Using one drug at a time reduces their risk,
by ensuring that they can tolerate them without adding another substance to the mix. This includes prescription medications, street drugs, cannabis, alcohol, etc. The substances may interact, and street drugs may also contain more undeclared opioids. Know the signs of poisoning and call 911 if you suspect it. Fear of arrest should not prevent people from accessing emergency services or calling 911. The Good Samaritan Drug Overdose Act can provide some protection for anyone at the scene of poisoning. Carry a naloxone kit and know how to use it. Be familiar with community supports and resources. These tips are for people who have no option but to use alone, especially during times of isolation like we're experiencing now. A large percentage of accidental opioid-related deaths happen in private homes, where people are either using alone or using in the vicinity of people who have no knowledge they are using. Avoiding using alone is always best, but for those who have no choice, there are now virtual supervised consumption services by app or telephone that can provide support and engage emergency response when needed. Using somewhere visible or asking someone to check in on you can be helpful. And when using alone, leaving doors unlocked so that people are able to enter easily in case of emergency, and having a naloxone kit visible is another way to reduce potential harm. There are a variety of resources listed in the following slides that support the general public, service providers, and healthcare workers when it comes to substance use, recovery, grief, crisis, and harm reduction practice. These resources can be searched online.
The additional training on this slide is publicly available.
These resources can be searched online. In conclusion, harm reduction is an evidence-based public health approach that is part of the continuum of care. Harm reduction is meeting people where they are on the spectrum of substance use. Understanding their experiences with substances is key. There are a variety of harm reduction services in Alberta that provide low-barrier, life-saving interventions to people impacted by substance use. It would be good to become familiar with these services available in your area. Harm reduction is a compassionate approach to care that prioritizes building a trusting relationship with the person impacted by substance use and empowering them with choices, building on their strengths, and understanding the impact of their lived experience. Thank you so much for spending your time with us today. I hope you're able to consider implementing harm reduction into your conversations and practice moving forward.
Thank you for joining us for this presentation on harm reduction theory and practice. If you have any questions, please contact the CLPNA practice team at practice@clpna.com.